Good evening, ladies and gentlemen. It is exactly 6 o'clock, and we need to start so that we can stick to time. First of all, let me apologize to all of you who have joined the meeting for taking your Friday away from you. Let me assure you that it is only for 1.5 hours. Then we can let you go and enjoy your Friday. I will start by introducing myself. I'm Dr. Virenga. I'm from the Fetal Medicine Group. I think from the Fetal Medicine Group, for the team who will be the panelists, there is myself and Dr. Ndagura and Dr. Tachoyo. And we do have another team, the neonatology team, the Neozin team, where we are going to have Dr. Mangiza, Dr. Stevenson, Alex Stevenson, and Dr. Ruchile Matuto. We are also joined by the pediatric surgical team, where we have Mr. Zimono. You probably interact with some of these panelists as they do their presentations. We've also invited some experienced colleagues amongst ourselves in perinatal issues. We have invited Professor Mjanja to be one of the panelists here, and we have also invited Professor Mjuru. We hope they will join us on time so that they can participate in the discussions. The main purpose of our gathering here is, as you can see on the screen that is being shared there, it's a Friday Perinatal Talk. We just want to talk amongst ourselves because we think it is the right thing to do. Besides, over the last few years, I think 3.5 years to nearly 4 years, there are lots of changes or developments that have happened in our field of perinatology. We have seen the advent of fetal medicine that has allowed more precision into fetal condition in terms of what it is, what should we do, when should the baby come out, whether the baby is, whether it is viable or it is not viable. All those questions are now better answered probably than before. At the same time, we've also seen a little development in the neonatal side when our 3 neonatal colleagues pushed the field of neonatology to the level where we are today, where probably some of the babies who used to be terribly afraid in terms of taking them out, they're now being looked after with probably better outcomes. But how can we know that the outcomes have improved? We can't just know by just saying they've improved. So it is the main purpose of this gathering for us to share with you some of the results of our work of the last few years. Then it is on the background of this work that we want to discuss and say, well, in the Zimbabwean context, what is it, or what is the gestational age, what is the weight where we should be comfortable, number one. Number two, what kind of message should we be telling parents when we see parents and they want to be delivered a baby who weighs 700 grams? What kind of message should you be telling them? I think gone are the days when you have to tell them that RCOG says this, ACOG says this. We do appreciate that knowledge, but we're not in America, neither we're in Britain, we're in Zimbabwe. So it is the Zimbabwean data that we want to share with you, and it is the Zimbabwean experience that we want you to relate with the parents. Our work is enabled very much by a team, by dedicated obstetric colleagues and also pediatric colleagues. So this is why we are all here, so that we can discuss and probably, come up with a good way forward. The program is outlined there. The time for opening remarks is up, and I need to get into my presentation. I will be sharing the first part Then my colleagues will take over at some point and share the other parts of this meeting. So the program is stated on the screen. It is as it is, except that Dr. Stevenson will not be presenting, but probably will lead the discussion, and Dr. Mangiza will present where Dr. Stevenson was supposed to present. So without wasting much time, I'll go into my presentation. If you would allow the presentation to run through, then at the end of the presentations, there will be room for all the questions and the discussion to follow. So to just begin, oops, right. So I'm going to be presenting on perinatal data. The perinatal data is not public sector data, but this is private sector data. The reason why I'm presenting private sector data is because we want to know the base of us, to say at our base, what is it we can do? How much can we offer at our base? Because that should be our reference point or our standard. We can't go and take the data where we know that there are a lot of confounders and a lot of limitations which are beyond us to deliver the care that we can deliver. So it is upon this reasoning that I thought, let me present the data, the outcome data of women we have seen in Zimbabwe in the private sector, specifically the ones who pass through fetal clinic and they are assessed and the delivery is optimized. And we talk to our obstetric colleagues and they deliver timeously. So this is the demographic data of the ladies I'm presenting. Sorry. So as you can see, it's a total of 607 women. It's a fairly high risk group. Even if you look at the age group, about 40% of them, close to 40% of them are actually above the age of 35. So long back, they used to be called grandparents women, but not in 2022. We no longer call these women grandparents. Women can have children at any age. The most important thing is risk assessment. So the term grandparents women really no longer applies in modern healthcare, where we know that the risk has to be individualized rather than to base it on the woman's age. Then in terms of how lean are the women, they are fairly okay. Yeah, we have, of course, 11% of them would probably classify as morbidly obese, but this is a high risk group of women who are referred for subspecialist services. Then in terms of diabetes, not far from the general population, the hypertension probably just, because these are hypertensive disease of pregnancy, just above the 6% that we know. And smoking about 4% is just slightly higher than what you'd get in the public sector in terms of the percentage of women who smoke. So relatively high risk if we just compare the Zimbabwean population. In terms of alcohol, 2% of them were taking alcohol in pregnancy. And if you look at the family history, you can see there's a lot of family history of diabetes there, high blood pressure, and preeclampsia. And 63% of them had given birth before. In terms of the babies, we assessed 16% of them were fetal growth restricted. This underlines that this is a high-risk group of women. This is important to remember this as we go on with our discussion today, that we are dealing with a high-risk group of women, and we want you to analyze the outcomes carefully so that we can make our own minds and say, how good are we as Zimbabweans? So in terms of gender, I don't know why my young people who prepare these presentations put this slide, so necessary. But you can see that's the even distribution of the gender there. Then in terms of the mode of delivery, again, being private sector and being a high-risk group of women, 44% of them, actually close to 70% of them were delivered by cesarean section, which is consistent with high-risk pregnancy care, let me say so, because these are high-risk group of women who are referred to us. Then in terms of the overall outcome, how many of them went to home? I mean, the short-term outcome, we're talking about delivery from hospital life. This is 93.1% went home, and the rest, unfortunately, suffered the above phase there. It's not a bad number for a high-risk group of women. I'll continue to underline this. Then in terms of the weighted births, we plotted them on the Hadlock, not the WU. Probably next time, it would be interesting to plot them on the WU chart. But you can see from the Hadlock chart here, the distribution of the weighted birth, quite a big proportion, like I highlighted on the slide, that 16% of them were small babies. You can see that they were falling below the lower mark there. Yeah, so this is a high risk group of women. Right. So now let's analyze the outcomes. Look at the outcomes. We're talking about short-term outcome, not medium or long-term. Short-term means these babies were discharged home alive. So before 24 weeks, our numbers are small for those babies before. We only saw 5 babies, pregnant women who ended up delivering before 24 weeks. Interestingly, 20%, if we look at the gestational age, some may wonder, why am I using gestational age and weight? The reason why I'm using gestational age is that it has been difficult. My pediatric colleagues have told me that it has been difficult to use gestational age, to marry gestational age with outcome because of the poor dating. But in our clinic, let me say more than 50% of the women are dated using first trimester. So our dates are probably more precise. We are in a position to be as good in terms of estimating data as possible. Probably we mirror close to what we know to what happens in Western nations. So the dating, we try to do it as accurately as possible using first trimester scan for the women we see. So we are able to use gestational age to analyze the data in this context. So between 24 and 28 weeks, we're looking at the babies. There were 18 babies who ended up being delivered at this time. And the going home rate was 22%, unfortunately. So you can see that before 28 weeks, we didn't do that great. About 20%, 1 in 5 babies went home. Unfortunately, the others didn't. This is the data we have, and the rest, as you can see, we had first 2 births, early neonatal deaths, and sometimes Massar's 2 births, unfortunately. Then between 28 and 32 weeks, we had 70% of the babies who went home. This is a high-risk group of women. So 70% of the babies were discharged alive home, and the rest suffered the fate, as you can see. Then between 32 and 34 weeks, 75%. Then after 34 weeks, we have 96% alive rate, and 37 to 30 to 40, this is 99.5. And after 40 weeks, none of our babies died after 40 weeks. So when you look at gestational age, we can probably conclude and say there is not much difference for babies born after 34 weeks. When you look at these figures, but babies born before 34 weeks, unfortunately, the outcome wasn't as good as we would want it to be. About 75% of babies lived. So this is the going home rate versus the gestational age. Now I'm going to take you to a slide where we analyze now the weights to say, according to weight, what percentage of babies went home. So this is now the weight category, where we categorize all the birth weights of the babies we saw in our clinic, and we wanted to know what happened to them. So as you can see, for babies below 500 grams, the numbers were not great. It was just 6 of them. Of course, they shouldn't be that too many. 50%, 33% we actually went home, bearing the small number there. And between 500 and 800 grams, again, bear the small number, 60% of them went home. If we look between 800 and 1,000, probably, let me say, just as good as between 500 and 800. It's about 60% again, 56% there. So just from the top graph, from the top pie charts here, we can probably conclude that between 500 and 1,000, 60% of our babies went home, for babies who weighed between 500 and 1,000. And 33%, unfortunately, below 500 grams. But I believe the numbers were to increase. Probably this number would fall as well, because the number is just too few. Then birth weight between 1,000 and 1,500 grams. Look at the difference. 81%, N was 16 there, and 85% for 1,500 to 2,000. This is the market change that we see with just, an improvement, a slight improvement in the weight here from the 800,000 to 1,000 to 1,500. This is the difference that we get in terms of the outcome, the estimated fetal weight. The weighted birth, sorry, not the estimated fetal weight. Then between 2,100 and 2,500, the survival was 97% of our cohort of 600 something women. Then between 2,500 and 3,000, 98% was the survival, and between 3,000 and 3,500 was 100, and 3,500 and 4,000 was 99%. And after greater than 4,000, we're talking of 100%. So the message here is above 2.5, probably the survival could stay the same all the way up to 4,000. But a base weight of 2,000 makes a very big difference compared to babies who are below 2,000 in terms of the alive rate. These numbers are very important to remember, because sometimes we have these high-risk pregnant women where we sort of delay the delivery, where the obstetrician sometimes may be anxious and say, can I take out the baby? And we say, please wait. We want the weight to appreciate a little bit. It is the basis of these numbers that we will be arguing to say, look, if we can wait for the baby to gain 2,000, we're going to remove the baby from having an 85% chance to be having a 97% chance of going home. That makes a difference to the expecting couple to know that my baby is a 97% chance of going home alive instead of an 85%. The same applies to the 1,000 and the below 1,000, where we'll be saying, look, your chance is 60%, but if we get your baby to 1,200, we may increase it to 80%. It makes a difference to the expecting couple. Then I think I've already presented these slides. Then in terms of admission to neonatal intensive care, 25% of the babies we saw got admitted. This slide is important. The reason why it's important is that it's just showing us the proportion of babies who were born at a certain age and the percentage of, sort of the proportion of those who were admitted to NICU and those who didn't. You may see that below here is no, because probably these babies were maternal stillbirth and they didn't have to be admitted. But when you look at the graph, actually the red one here, you can see that it follows a certain pattern and starts dropping after 37 weeks and going all the way to 41 weeks where it continues to drop. What is the message? The message is that if the baby has no issues, serious issues, sometimes it's better to wait for 37 weeks to be completed, so that we take care of this NICU admission as well. Because sometimes people will say, should I take it at 35 weeks? Should I take it at 36 weeks? Yes, you can take it out at 36 weeks, probably it's 2.4 kilo, and you are happy with the weight. But there is also the issue of NICU admission for these babies who are below 37 weeks. So these are some of our arguments to say, let's wait to 37 weeks if the baby is not in trouble, because there's no reason to base the baby's bubble if it is happy within its mother's womb. So this is our data, which I just presented. I didn't comment much on the data because I want the comment to come from you when my colleagues finish presenting. Yeah, so just right on time, I finished my presentation. My next colleague, I'll stop my share so that my next colleague can go on and present the data from the neonatal side. Then after they're done with the presentation, we can discuss. Thank you. Please, you can go ahead, Dr. Mankija.
Good evening, everyone.
Good evening, Doc. We can hear you loud and clear. Unfortunately, the other participants are in the webinar, so
Oh,
they
yeah,
so
they can't see. All right. Okay, let me just, are you seeing my slides? I want to put it on slide share, though.
We are seeing the screen, but the slide is not yet clicked, I think. If you could open the slide, then when you share, you go straight to where the slide is. We're seeing your desktop screen with recents and...
Oh, so maybe I should press new share?
Yeah, please do that.
Okay, all right. There we go. Are you seeing it now?
Yeah, it's appearing now. You can put on slideshow. Thank you.
Okay, I'll put it on slideshow. Okay, can I go ahead and start? Is everybody hearing? Yeah. Can you hear me, Dr. Verenga?
Yes, please go ahead.
All right, thank you. Thanks to Dr. Verenga for coming up with this webinar and inviting us to present. My name is Dr. Marsha Mangiza. I'm a pediatrician, neonatologist. I've got a disclaimer that I did not prepare these slides. These slides were prepared by my colleague, Dr. Alex Stevenson, but unfortunately he had something pressing and he's not able to attend at the start, but he will join us in a couple of minutes. So I'm going to be talking about the limits of viability and a bit on the international preterm labor guidelines. All right. So the limit of viability is the age at which a fetus becomes potentially able to live outside the mother's womb, albeit artificial aid. And then some data will say, you know, it's the fetal age at which there's a 50% chance of long-term survival outside the mother's womb. So why do we want to know this limit of viability? We want to know it because we need to establish the limit between the beneficial and the futile management in extremely preterm infants. So extremely preterm infants are very vulnerable little ones. And we need to know whether it's the baby is better in, there's an acronym BEBO, better in or better out. So we need to see if the baby is out, is our management going to be beneficial or it's futile? So I'm going to talk a little bit about our experience, but unfortunately our data is just data which was collected retrospectively. We had no consent, you know, it's not like we didn't have any consent to a study, but we just collected data over a year for the babies that we took care of in 3 private hospitals as the NeoZim team. So the NeoZim team is myself, Dr. Alex Stevenson, and Dr. Letile Mazuzo. Alex collected this data just to see what are the outcomes of the extremely low birth weight infants, which is the babies who are under 1,000 grams that we looked after in 3 private hospitals over in 2022. So 30 extremely low birth weight infants were referred to us in the year 2022. Like I said before, this is 3 private hospitals where quite a number of newborn babies are born and referred to. The gestational age of these babies ranged from about 23 weeks to 32 weeks. And out of the 30 babies, 13 of them died, which makes a mortality of about 43%. So that's quite a huge mortality in our babies who are extremely low birth weight. So I've got a table here, which is just showing the survival of the extremely low birth weight patients in 2022. This is not all of them, but these are the ones that were referred to our team. So you can see from the table here that between 400 and 499, all the babies died. So the orange is the babies who died and the blue is the babies who survived. And then between 500 and 599, none of the babies survived. Between 600 and 699, none of the babies survived. But when we start going to 700 to 799, about half of the babies, we only had 6 babies, half of the babies went home, half died. Between 800 to 899, we've got a bit of a better survival there, with 7 babies surviving out of 12. And then between 900 and 999, I think we get a bit more comfortable. More of these babies actually survive, according to the data that we had from last year in 2022. All right, so this at this table, the next table is just showing our survival data. I mean, when we're going to be discussing viability, we need to also discuss, it would be better to have guidelines for the nation as a whole, as opposed to say, we've got guidelines for private and we've got guidelines for public. But I mean, we can discuss this at the end of the discussion. This is just mortality according to birth weight category from data from Harare Hospital, which was done. This is a study which was done by one of my colleagues. And what it basically showed is the first row is that in our extremely low birth weight, which is the population that we are talking about, the mortality rate is very high, 91.1%. So out of the babies that were seen in the study period, those were extremely low birth weight. More than 90% of them died at Salim Mugabe Hospital, which is one of the public institutions that I work in, or that some of us work in. So what are some of the challenges that we face on a practical basis when we are taking care of these extremely low birth weight babies? When the obstetricians call us and they say, you know, I've got a 26-weeker, our heart rate starts going up because we know we're going to have challenges. So one of the challenges that we've had is we've had unclear guidelines as to what is the age of viability in our nation. I like what Dr. Verenga said, that we're not talking about things that happen overseas. We need to talk about what actually happens in Zimbabwe. So we tried to look around, and we noted that there were actually no guidelines as to how these babies at the limits of viability should be resuscitated. At the end of my discussion, I'll talk about our proposed protocol of how we should manage these babies. The other thing that we face challenges is we've got limited resources. These extremely low birth weight babies need nutrition right from day one. So they need total parenteral nutrition because we're not able to feed them right from the start. We do not have total parenteral nutrition in this country at the moment, but we are working hard to try and get to sources so that it becomes legal, and so that we have it available for our extremely low birth weight babies. We've sourced it out from other countries sometimes, but it's not easy. We've done it mostly for surgical babies, but we need to do it for our extremely low birth weight babies in order to improve their outcome. We need to have a breast milk bank because when these mothers delivered at 25, 26, or 27 weeks, they've got no milk. The milk usually comes in day 2, day 3 for mothers who've delivered term babies, and it can actually be even up to day 4 for the mothers who've delivered preterm babies. But time is of essence. Every hour, every day that you don't feed this extremely low birth weight baby increases the risk of mortality for these babies. So we need to have a breast milk bank in our country, which we don't have at the moment. Plans are underway. We haven't made that much progress, but we have started trying to work on these things. We also don't have central lines. We don't have tiny central lines to be able to use in these small ones. So sometimes we use cannulas and we run out of veins and we end up calling our colleagues, Mr. Zimun. I remember one day we're having a discussion with him. He's like, why don't we have a protocol to say for if a baby is under this weight, we start by putting a UVC, because sometimes when we end up trying to put central lines, it might be, I mean, these UVCs, it becomes a bit late, but also UVC is not good enough because it only lasts for 10 days. But there are some lines which are called peripherally inserted central lines, which can last for up to 2 or 3 weeks, which we actually don't have in this country. We also don't have, some centers, even private ones, don't have infusion pumps, which we can use to give total parenteral nutrition. These babies are small and quite sick, and most of the time our institutions have inadequate staff. When these babies are born, most of the time they require intensive care nursing. What this baby requires 1 nurse per baby, or sometimes even 2 nurses on 1 baby. But most of the time at the facilities that we work, you find that you've got a nurse taking care of an extremely low birth weight baby and 3 other babies. So it also makes our outcomes become very poor. And also we've got, the there's poor parental support. The mothers of these babies go through so much trauma. We don't really have good support systems or good support centers or counseling services for these mothers. All right, so just this is one of the references that we used when we came up with guidelines for what we think we may do for babies who are at the limit of viability. So from an international perspective, when a baby is less than 22 weeks, there's generally an agreement that at less than 22 weeks, there is no hope of survival for the fetus or the neonate. And then week 22 to week 22 plus 6 is considered to be the cutoff of human viability. There's no scientific society recommends performing any kind of active treatment on the mother that is aimed at protecting the fetus. And then at greater than 25 weeks, there's a general agreement that for weeks 25 to weeks 25 plus 6, antenatal steroids are recommended, prenatal transport, moving the mother to a place where she can deliver, where there's a good quality neonatal care, and the cesarean section are also indicated to protect the fetus, and resuscitation is offered to all infants without fetal anomalies. And then between 23 to 24 weeks, from the guidelines that we reviewed, it seems that 23 to 24 weeks are sort of gray zone, where recommendations suggest resuscitation on an individual basis and according to the parents' wishes. In some countries, this gray zone extends through 25 to 25 plus 6. So all the official guidelines in the research and on perinatal care surrounding the threat of extremely preterm births come from industrialized countries, because we could not find any guidelines in developing countries. But we thank Dr. Verenga for the data that he has shown us. So how we approached the problem when we thought, let's come up with viability guidelines that we can actually work with. We thought, one, the baby's interest is paramount. So whatever we do, we must do what is in the best interest of the baby. And the parents are critical partners, and they're the baby's custodians, and they need to be active participants in viability discussions. So they need to know what the percentage of survival is at a certain birth weight. They need to know what their baby is going to go through. If they say, let's resuscitate, they need to know that baby is going to be put on a ventilator. We are going to intubate, put a tube down the throat. Baby might bleed, all of the things that baby has to go through. We try and counsel the mother so that they are aware of the complications that this baby will face. And the neonatal outcomes are improving with time. And what was standard practice at one point may become obsolete later in Zim. So medicine is an evolving science. What we're discussing here may be relevant for today, but we need to keep re-looking at these guidelines and seeing if we need to change them. And then basically these guidelines represent NeoZim's current practice and private practice in Harare, and should not be construed as national guidelines and are not applicable in different settings. All right, so the most accurate gestational age estimates come from in vitro fertilization, where the exact gestational age is certain, and also from ultrasound scans done before 12 weeks. So we're grateful to the fetal maternal medicine team that more and more scans are being done early, before 12 weeks, which are accurate to between 5 to 7 days. And then ultrasound scan done between 12 and 20 weeks are generally accurate within 7 to 10 days. And so a baby said to be 23 weeks and 6 days may actually be in fact 25 weeks and 2 days, which illustrates that in borderline cases where you're not sure, it may be important to have pediatricians or a neonatal team present at delivery to help assess the perceived viability. So we assess the postnatal age using the Ballard score. And so what we decided was that at 26 weeks, all preterm babies at 26 weeks should receive full resuscitation, unless there's some other reason not to. I think we'll go back on the discussions. We'll see what the outcomes were like on Dr. Verenga's 26 weeks data. And then at 25 weeks, most babies at 25 weeks receive full resuscitation. However, if parents are against resuscitation, their opinions should be listened to, because like I said, these babies go through a lot. And then in addition, the need for prolonged resuscitation or escalating care in ICU should take into account the state of the baby, the probable prognosis, the pain and the discomfort that may be caused to the baby or family, and the wishes of the parents. Babies who are born at 25 weeks who have not received antenatal steroids or who are born outside specialized centers will have a worse prognosis. So if these babies are outborn, as in they are not going to have to be transferred to another center and they are 25 weeks, it might be better to keep the baby at the center because the prognosis becomes much poorer. Then at 24 weeks, the prognosis is generally poor in our setting. And at this time, the parents must have a full and frank discussion to try and determine what is in the baby's interest. If the parents are supportive, the antenatal care is optimal. That is, the mother receives antenatal steroids, antenatal antibiotics where appropriate, and magnesium sulfate, and the baby is born in a specialized center with an expert neonatal team at delivery. It is not unreasonable to attempt resuscitation and admit to ICU. However, if the baby's condition deteriorates and the further intervention is futile, it is not appropriate to continue escalating intensive care. So at 23 weeks, it is generally not appropriate to try and resuscitate babies under 24 weeks in our current settings in Zimbabwe. In our practice, which had not been for that long, but we've never seen a baby under 24 weeks survive. I think the earliest age that we've had is about 25 weeks. 25 weekers, we've had them go home. The priority is the baby's comfort and the family's precious time with their baby. The parents should be allowed to hold the baby if they want to, and care should focus on keeping the baby comfortable. Supplemental oxygen is not appropriate if the baby is struggling to breathe, and providing psychosocial support to the parents. However, given the limitations of gestational dating, it is not unreasonable to have a neonatal team present at deliveries to make a rapid assessment of the baby at delivery, but it is inappropriate to start resuscitation if the baby is clearly unviable. So the antenatal corticosteroid, the FIGO guidelines from 2022 say that between 24 and 34 weeks, one course of prenatal corticosteroids should ideally be offered 18 to 72 hours before preterm birth is expected to improve outcomes for the baby. However, if preterm birth is expected within 18 hours, prenatal corticosteroids should be administered. And one course of the steroids should be given, whether you use betamethasone or dexamethasone. I see here most obstetricians use dexamethasone. And then in women in whom preterm birth is expected within 72 hours and who have had one course of corticosteroids more than a week previously, one single additional course of prenatal corticosteroid could be given if at risk of imminent delivery. So if my mother needs a repeat dose, one repeat dose would be appropriate. And then generally after 34 weeks, antenatal corticosteroids are not recommended routinely. And then for magnesium sulfate, the FIGO 2021 guidelines say that in women at risk of preterm or imminent birth from viability to 30 weeks of gestation, so we need to establish what this viability is, but for us, we had said maybe at 26 weeks. From viability to 30 weeks of gestation, use of magnesium sulfate for neuroprotection of the fetus is recommended. Then in pregnancy below 32 to 34 weeks of gestation, the use of magnesium sulfate for neuroprotection of the fetus should be considered. And then the timing of the MAG sulfate, it should be administered when early preterm birth is planned or expected within 24 hours. And then when the birth is planned, MAG sulfate should be commenced as close as possible to 4 hours before birth. And if delivery is planned or expected to occur sooner than 4 hours, MAG sulfate should be administered as there is likely to be an advantage from administration within this time. And then the regimen, I'm sure you all know it, for fetal neuroprotection, that a loading dose of 4 grams and then 1 gram per hour maintenance dose. And then there's also the issue of tocolysis, that nifedipine, spontaneous preterm labor, when it's suspected, you can use nifedipine as a tocolytic. And then the dose is an initial oral dose of 20 milligrams, followed by 10 milligrams every 6 hours for 3 to 7 days, or until transfer is complete, whichever comes first. Thank you very much for listening.
Thank you so much, Dr. Mangiza. Wonderful presentation. Without wasting much time, let's proceed to the next presenter. we are very much on time, ladies and gentlemen, and we hope this will afford us enough time to discuss or for questions to be answered. So, Mr. Zimono, are you ready to share your screen? Dr. Mangiza, you may unshare your screen so that Mr. Zimono can come in. Yeah, there he is. Thank you so much. Please go ahead, Mr. Zimono, and share your screen. You can unmute yourself, Mr. Zimono. I think your microphone is disabled from what you can see there.
Can you see my screen?
Not yet. Please try again.
Not yet. Okay.
I don't know. What is happening is that your microphone is disabled. Your screen comes and then disappears. If you can unmute yourself first and click the PowerPoint presentation.
So I'm on the PowerPoint presentation now.
Yeah, you can try to share it because we can't see it at the moment.
Okay. How about now?
Not yet. Maybe you might need to close all the other windows except your Zoom and your PowerPoint so that when you click sharing the screen, you only see one window there, which is the PowerPoint.
So I have only two windows open, the PowerPoint and the Zoom client.
Yeah, you can try again
So
screen sharing because you can't see it.
How about now?
No, not yet. Then in the meantime, while Mr. Zimono is trying to share his screen, the panelists, there are some questions which are in the chats, in the chat platforms. I think Mr. Svanda, I think it should be Dr. Emmanuel Svanda. He's my colleague who has asked the question, is your decision for ventilation of babies based on weight or gestational age when it comes to extremely low birth weight? And at which weight or gestational age do you ventilate them? So you can think about this so that when the question times come, when the answer time comes, you guys will be ready to answer. Then as for the rest of the participants, you may use the chat box for now. Probably you will be able to speak during the questions and answer segment, the discussion segment. But for now, you can just type your questions so that people can think through the answers so that they are more efficient. Mr. Zimono, do you want to try again to share your screen because we don't see it yet? Mr. Zimono, are you still in the meeting? To manage our time, because we expect that there will always be challenges. Maybe Thelma is going to get in touch with you, Mrs. Moon, so that you can send your presentation to her and it can be shared from this side. But while we are doing that, Mrs. Moon will present as soon as his presentation is shareable. Maybe we could start the discussion concerning the presentation that have happened so far while this is being sorted out. I think Dr. Stevenson will take over the discussion session to allow us to begin to discuss. And probably, maybe we can also allow our panelists to comment before the discussion starts. So Dr. Stevenson, it's over to you now. Let's start the discussion. As soon as Mr. Zimono's presentation is ready, we'll take just a 10 minutes break for his presentation to continue so that we don't delay. Thank you.
Dr. Vedeng, I'm not sure if Dr. Stevenson has joined yet. I'm not able to see the participants. This is Dr.
Double click to enter full screen mode. That's what the screen is saying to you, Mr. Zimono. Dr. Stevenson, okay. I can see you are there, but you are muted. Yeah. Are you? Great. So this Dr. Zimono screen is coming. You can remove the Zoom. Yeah. Excellent. Okay. So let's continue the presentations then.
All right. So let me take it from the top. Am I in slideshow now?
I think it's coming, the slideshow list. Yeah, good to go.
Okay, thank you very much for waiting, and my apologies for that debacle. So I'm just going to give you a surgical perspective to the issue in discussion. I've only about 5 or 7 slides to share with you. And as you all know, I have I've been working as a pediatric surgeon, but I have just one disclosure that I'm now working with the pediatric surgery department of the Pioneering Health Group. So we need to be able to define what we mean when talking about issues of viability. And Dr. Mangiza has gone to town giving us the medical side of viability. I'm not going to go through the other possible definitions of what we would mean by viability when we're talking about extremely low birth weight babies. But we must be cognizant of the fact that parents do have a view to what they mean by viability. And even amongst couples, the two parents can have different views as to what they mean when they're talking about viability of the baby. Society also at large has differences as far as their definition is concerned. If you look at other parts of the world, their definition of viability may just start from the moment that you have conception of a fetus. And then most importantly, we will not forget the law. The law has its own definitions as far as viability is concerned. And as medical practitioners, we must know the implications of what these laws mean. We know there are already abortion laws in almost every country, and these abortion laws are generally based on gestation. And whenever we're talking about our limits, whether low or upper thresholds of viability, we must be thinking about what the laws of whichever environment we are working in say as far as viability is concerned. Obviously, as you can appreciate from these presentations, you can see that it's very important to have a solid team that works with extremely low birth weight patients. At the center of it all, we have the patient themselves, and then we have various other stakeholders which are almost equally important: the parents, the various medical practitioners, not forgetting the specialist nurse practitioners. I think without this important, or these important pillars, we cannot have the best outcomes that we all look forward to. And even when we are thinking of bringing down our lower thresholds of viability, we must make sure that we have all the stakeholders on board and they're working together to make sure that we get the best outcomes. Dr. Mangiza has presented on the guidelines that are environment specific, specific to our own environment. These guidelines may not have been very adequately pronounced in the past, but the coming together of the fetal medicine unit as well as the neonatology unit makes us come up with guidelines that address what we would call best interest standards. Obviously, we have to use the plural standards when you're talking about best interests, because the best interests are not only, they don't only concern us, the adults, they don't only concern the medical practitioner, the parents, or the law, as I previously stated. They also concern the best interests of the baby or the fetus that we are trying to address. If we insist on helping them, are they going to be helped without undue pain, without undue suffering? Are they going to have the quality of life that any one of us would wish for? Are they going to be a useful member of society? And all these best interest issues come into consideration when we look at the matters of ethics around this subject. I've already alluded to the issue of culture and the law, but I'll just highlight some of the challenges that we in the neonatal surgery unit face when we are dealing with these babies. Some of the babies already have prenatal diagnosis of quite serious surgical conditions like congenital diaphragmatic hernias. And sometimes we have to meet with parents who have had a conception which they were looking forward to being normal, and unfortunately they have to come for a prenatal consultation with the surgeon. It's never a good thing, and there are many emotions that have to that are taken that come on board when you are discussing these issues. So those discussions on their own, they are huge challenges, let alone when the child is eventually delivered with severe prematurity. Then we have specific problems that are inherent or that come with the baby themselves. I don't need to go to town concerning the problems of prematurity as far as breathing, immature cardiovascular system, immature immune system, and the like are concerned. But coming to attending to the babies themselves, you need a highly motivated and a highly experienced team of anesthesiologists who should be part of the team from the beginning. And once you have had reasonable stay of the patient as you try to save them, you will face challenges of access for nutrition and access for other intravenous medications and general care of the patient. Dr. Mangiza has already highlighted some of the dilemmas that we have had as far as vascular access is concerned with these special babies. But it goes without saying that ultimately working as a team is what makes everything come back to reasonable levels. So to us, I think starting with these presentations and discussions with the rest of you colleagues is the beginning of steps towards even a greater goal. And this goal we are hoping at some point we will come back and be discussing issues of operating on these babies even before they are born. Once we are over the stage of dealing with the extremely low birth weight patients, we are then going to look at possibilities of having to operate on them before they're actually born. Again, we will need to discuss issues of viability, come up with what we consider to be lower limits and what we consider to be upper limits. And we also need to see whether we are going to widen our gray zones or have them shortened. Thank you very much for your attention, and I'll give back the screen to Dr. Verenga.
Thank you so much, Mr. Zimonu, and well done, everyone, for sticking to time. We are within our time frame to now go on to the discussion. Is Dr. Stevenson available now or no? Dr. Stevenson, are you available to lead the discussion, or we can start, then you join us? You may join us later, right? So before we address the questions and before we go to the discussion, wanted to give time to some of our panelists. We invite into this meeting Professor Mjanja, Professor Mjuru, and also our colleagues from both the fetal medicine side and the neonatal side who are panelists in this meeting to comment or to give us their perspective on what they think so far. I think you can unmute yourself and speak when you are ready, so that we...
Okay, I'm ready.
Thank you, Prof. Please go ahead.
Yes, I've just got a few comments. I think we should people should make a plan, or you and the team, Fetal Medicine Foundation, should make a plan for like a 2-year or 3-year assessment of quality of life, so that we know it may cause revision of the limits. At the moment, we are talking of the limits of viability, but what are the limits for quality of care, quality of life? So maybe quality of life is not so good. And I've always been surprised by some of my patients who disappear from my care. They've done very well. The baby was 800 grams. They stayed in the NNU for 2 months, went home. You don't see her for 2 years. And then you bump her in the shopping center one day and you say, why didn't you come back? And then you ask about the baby, and the baby's got learning problems. And I've discovered that when people have got problems with the baby, I don't know, they don't come back to the obstetrician to say, this is what happened. Did you know we are coming to tell you this is what happened? I think we need to find a way of identifying future problems, even if the baby has been discharged in a good state, so that we can learn more about the limits of quality of life. The other point I wish to make is that the communication is such a problem with parents who are reading every day on the internet of isolated cases of babies that have survived at 22 weeks. And they say, why is my baby being treated like this? In Japan, a baby delivered at 22 weeks and it survived, etc. There's a big problem getting the correct balance between being optimistic and very pessimistic. And one woman once said to me when I met her, she said, this is the baby that you thought was going to die. And the baby was obviously very healthy, but this was a 26-weeker. A woman who eventually wrote about it in a podcast. And I just gave the information as was available at that time. But she thought that I was, I was giving a deliberately pessimistic view, which would affect the neonatologists in their management. Okay, so I think the worst case scenario happened a couple of, maybe 5-6 years ago. And this is for the obstetricians. I think if a baby comes and is alive and is less than 26 weeks, just make sure that the baby is not delivered in a ward where there are no midwives. Because what can happen is that the baby is sent to a general ward or a ward which is not a maternity ward because the woman is 22 weeks. And then the baby delivers in her bed, and there are none midwives running around, insensitively coaching the gestation, etc. So one woman caused a lot of trouble at the avenues for some years because she said that she delivered next to the lift. At 22 weeks, we should have survived. So after a lot of pain and a lot of legal processes, we then prevailed. But her argument was that our care was so careless that we allowed her to deliver by the lift at her visiting hour, and everybody watched this delivery. It couldn't be prevented because she was not in a maternity ward, and the staff in that ward could not diagnose impending preterm birth. Thank you.
Thank you so much, Prof. So thank you so much, Prof. Maybe we can allow the next, I don't know if Professor Mjuri is able to comment. To give us a perspective. Professor Mjuri is unable to unmute. Let me see if I can unmute you from this end. Let's see. I don't seem to see where you are. Let's see. There you are. Right. I've promoted you to a panelist, so probably I think you can now unmute. Just try or rejoin now as a panelist, Prof. Well, I'll give my colleague, Dr. the time to comment while Prof joins, and also probably Dr. Ndagura and Dr. Lachayo. Please, you may go ahead and comment.
So, thank you. I don't know if I can go ahead. Thank you. Is that okay?
Yeah, you can go ahead, Prof, so that we can hear you.
Okay, thank you very much. Thank you both to the fetal medicine team and to the neonatologists for their presentations. I was a bit surprised but happy to learn that women in the private sector, a lot of them are actually booking within the first trimester. That I think is commendable, because we know that our women usually book late, and even learned women usually don't book within the first trimester. But from your data, you sounded like the majority of the women that are coming to you are booking within the first trimester. So that's to be commended. And maybe you can share the trick that is working. I think that what Prof Munjanja said is what I had also wanted to say is the first thing, that we really, really need to look at medium to longer term outcomes other than just the initial discharge in terms of viability. It's good to make them survive, but we also know that the risk of neuro problems and neurodevelopmental problems is very high, especially the lower the gestational age. The advantage that I tend to see in the babies that I've seen in the past was that quite a big percentage of our preterms are also intrauterine growth restricted, and that tended to work on the slightly positive side, that you find that their outcomes were a bit better when they are intrauterine growth restricted. The one thing that I also found is that moving on to parents and counseling, besides the fact that you will have counseled them in terms of the risk and the outcomes and the longer term probability of problems, they don't hear you. And in our culture, it's very difficult to accept no intervention, to accept or stopping intervention sometimes, because there are times when you might want initially having thought that the baby would do well, and then you find that there are complications and you might want to reduce the level of intervention that you're doing. But culturally, it is very, very difficult. I think those of you who have worked in the developed world and who have interacted with parents from that end will find a marked difference with our parents. Even it's not about education. I think it's about culture. It's about being able to face it and say, I'm the one who caused my death, the death of my child. And there's this notion in our culture that you give everything for your child. You would rather die for your child to survive. And that's the sort of attitude that a lot of parents have. So that there needs to be a lot of counseling, a lot of support. And I have had patients who sometimes agree and change their mind. And then they come back and they're like, no, we've had a discussion as a family and we think that, no, you can't stop or you can't do this. There's no way, you have to give this baby a chance. Yes, we are getting more and more parents, fathers seem to make decisions that are more solid than mothers. Mothers tend to want to cling on to their child, even if you tell them that the child has got an intraventricular bleed, grade 4, and they will likely not to have a good outcome. They still want you to do something. But I've heard in my experience, fathers are the ones who say, if he's not going to be a man that I can go and watch tennis with or do this with, then doc, I think I'm not prepared to take that. But it takes a lot of counseling. So that's an area that I think the neonatologists maybe can, I don't know whether, because it's easy to come up with guidelines. It's easy to say that at this age, they're not viable. But like you rightly said, it needs the parents and everyone else to be part of it for you to be able to then take that step. And sometimes on the private sector, it's also unfortunately about cost. Sometimes you have to carry on, and yet it is at a very high cost for the parents when you know that eventually the outcome is not going to be good. And in our culture, money doesn't matter, it's the life that matters. Once again, and they come and tell you that, no, mara inabasa, chero upenyu wemwana, and it's the child's life that matters. When you're trying to tell them that, yes, money doesn't matter, but money does matter at some point. And then the issue that I think Dr. Zimuno highlighted is about the nurse practitioners and the intensive care nurses. That's one area that we really need to continue to strengthen in our situation. There was a time that we worked as a team and sent a group of nurses for a little attachment in South Africa, and then they came back with a little bit of knowledge, but there's a lot of learning that is needed, and there's a lot of support that is needed. And unfortunately, nowadays, there's a lot of attrition as well in those that you will have invested in. And then the other major problem, unfortunately, on the private side is about tariffs and grading of units. You will find that the avenues might be grade A+ or whatever, those who assess these hospitals in terms of what they're allowed to do, how many nurses per patient and what they're paid. Whereas another unit might be a B+, and so how much they can claim will determine how many nurses they'll put. Whereas we know that this nurse, like Dr. Mangiza highlighted, that the baby needs a nurse for himself or herself, or sometimes two nurses, but the hospital cannot afford that because they just are not rated or ranked at that level by whoever does that ranking. So that I think is also a very common thing, and unfortunately we need to address it because it is something that affects the care of these small little darlings of ours. I think I will stop there and allow others to comment. I can come in later on. Thank you.
Thank you so much, Prof. Very valuable comments there. Yeah. I've asked my colleagues, any more comments from Dr. Mazuto? Dr. Ndagura Tlachayo? Okay, while we're waiting for them to come in, maybe let me. Yes, please go ahead. Please go ahead.
I just want to say thank you, Prof, for your input. Prof is one of the pediatricians who has a lot of experience in taking care of these extremely low birth weight babies. I think we forgot to involve another important member who should have also joined the team. I think we should have involved Dr. Chikaram Dawarima, who's a developmental specialist. I think she's been practicing a developmental specialist maybe for about 3 or 4 years or so that she can also tell us what the outcomes are of some of these babies that we've that have probably been taken care of by our elders like Prof. Mujuru, Dr. Powell, some of these people, Dr. Tika, were taking care of these extremely low birth weight babies. That what are some of the outcomes, what are some of the developmental issues that they face later on? Because it's not only about survival, like what Prof is saying, but it's about survival without significant neurodevelopmental sequelae. I think in the meetings in the future, when we're discussing such things, I think we probably should invite a neurodevelopmental specialist.
Excellent. Is Dr. Chikara in the meeting? Because she's in the meeting, I think her comments will be valuable.
Okay, yeah, that's true. If she's in the meeting, it would be great. It's just that I can't see who's in the meeting.
Are you in the meeting? If you're in the meeting, please indicate on the chat so that we can promote you to give us your valuable comment. While Dr. Chikara probably is doing that, let me just comment on 2 issues. One raised by both profs. The first one is on medium to long-term data. One of the things that we have tried to really do is to create an electronic database, especially in the fetal medicine unit, to allow us to have the baseline data. Because, our greatest enemy, I think, in our institution is the lack of electronic database. Hence, we don't have database in our fingertips. But we've tried to address that gap by having an electronic database. The reason why we are able to present this data is because all our data is electronic. And what we need to do is just click some few clicks on the computer and export the data to Excel and ask our young people to analyze the data. That's what it takes if you have electronic database. So we now have the base. So our data is for short term, I think 2 years or so. So we will be able now to follow up these patients. Of course, we are going to task our young researchers to do some of this research, so following up these babies, especially babies with condition, the FGR, so that we can know the medium to long-term outcomes of these babies. I think the neonatal team, especially with the neonatal, there's also data. But I think we have reached a stage where we now need to mine the data so that we can present our local data of real Zimbabwean patients and with the real outcomes of what happened to those we looked after, so that we can counsel them better. Then when it comes to guidelines, I think guidelines have moved nowadays. Guidelines used to be prescriptive, telling the practitioner what to do so that the patient. But modern guidelines shouldn't be like that. Modern guidelines should give the practitioner the message, like these numbers we are talking about, to say, look, if we deliver you before you are 1,000 and you are between 800 and 1,000, your baby is a 60% chance of being home. It's probably a 20 to 40% chance of neurological morbidity, and based on the local data. So that in turn, the couple can make an informed decision to say how much do they want you to fight for their baby. But the decision on how far you go should never be yours. It should always be the couple's to make. After you have given them enough information supplied by the guideline, because not everyone has to go and read or to research on the numbers, but the guideline should have the numbers to guide any practitioner who wants to use the guideline and say, when I meet a woman whom I'm going to deliver with an 820-gram baby, what kind of information should I be telling them to allow them to make an informed decision in terms of how far they have to go in caring for their baby? So I think this is where the data comes in, to say we need data both from our side and the neonatal team side. I think it's one thing we have to be serious with, to know that we need data. Without data, we always continue to say, what do Americans say? What do the British say? But this doesn't help us because the conditions are not the same. So yeah, so those are the comments I wanted to pass. Then in terms of first trimester, Prof, our cohort of patients, it's said that most of them book in first trimester, to be honest with you. Maybe it's because of the code. I didn't highlight the socioeconomic status, but probably in future research I should. But these are people of high socioeconomic status we are talking of, and they book in first trimester. They are very aware, most of them, of the pregnancy, and they book in first trimester. They do the right things. They are screened for Down syndrome. Let me say the screen for Down syndrome, about between 60 to 80% of our clients do the proper screen for Downs. So this is the cohort I'm referring to. I'm aware that probably the majority of women are still booking late, as we know from the national data. That I think about 26% book before 16 weeks, and the rest don't. So yeah, it's still a work on our side, the obstetrician, to advocate for earlier booking. We are trying to do it, but yeah, it takes time.
Thank you, Dr. Irenga, for...
Hello, everyone.
Yes, please.
Okay, thank you. Sorry, I was having technical problems, but thank you, everyone, for your input. Dr. Irenga for facilitating this. Prof. Mjanja and Prof. Mjuru for your input. I think most of the things have been said, but I just want to highlight the importance of antenatal counseling, as Dr. Mangiza said. I think it's something that most of us don't usually do, but I think it's very important for these patients well before the baby is born. If you're anticipating premature delivery, it's important for us to give antenatal counseling to these patients, telling them about the outcome, the possible outcome of the babies, what we can offer the baby, and then also agree with the parents on a plan for the baby. I know it's difficult to stick to a plan, but it's very important. And we find that parents who get antenatal counseling tend to accept outcomes better because they know their baby may have an intraventricular hemorrhage. So when it happens, it's easier to explain to them. So antenatal counseling is something that we need to improve on. And also the issue of having babies inborn versus outborn babies. And I'm sure some of the obstetricians here have heard us saying, why don't you transfer this mother to such and such a hospital so that the baby can be delivered there? So it's better to transport the baby in utero than for us to transport a 500 grammer when they've been born. So sometimes when we advocate for these things, it's all because babies that are inborn actually tend to fare better than babies that are outborn. And then Prof touched a bit on withdrawal of care. In our setting, it's very difficult. From our experience, most parents don't want to make the decision. We've had one or two cases where we've had to withdraw care, where the parents have agreed, but most parents tend to leave the decision to the doctor. But in cases where you've got maybe grade 4 intrauterine hemorrhage, we've had one or two parents who've agreed to withdraw care. You stop all treatment and allow them to hold their baby until the baby dies. Yeah, so, but obviously that is something that we need to do more, because sometimes the treatment that we give to these babies becomes futile. You continue inflicting pain to the baby when you know that whatever you're doing may actually not even improve the outcome of the baby. So it's something that we need to improve on and involve other specialists that specialize in palliative care. And then it's not all gloom and doom. Dr. Verenga, can you allow me to share? I just want to share, I just have 3 slides.
Yes, there's a panelist you can share, Dr. Amadu. Just go ahead and share. And
where do I click to share? Or share more?
There should be a share button. Yeah, please go ahead.
Now I can't find my presentation. Where is it? There it is. Okay, can you see my screen?
Yes, we can see your screen. You can probably put on slide.
Can you see? All right.
Let's see the slideshow there.
All right, sorry. I'm saying it's not all gloom and doom. Yeah, we've had some good outcomes. And I think as Prof said, it's important for us to follow these babies long term. So generally for us in our clinic, we follow them up to about 2 years. That's routine follow up. And then after that, most of them tend to disappear from our care. But at least the preterm babies, we try to make sure we follow them up to at least 2 years. I've had permission from the parents to share these pictures with you. There's a disclaimer. So this baby that you see here was 595 grams. And this is her now. So there is hope. It's not all doom and gloom. This one was 600 grams. This one was a 26-weeker. And this is him now. So I know it's been all depressing, 45% mortality rate, but there is light at the end of the tunnel. And I think if we continue to invest more in the care of these extremely low birth weight babies, we will get to having 24 weekers surviving in the long term. Thank you. Thank you. Over to you, Dr. Verenga.
Thank you so much, Dr. Martin. And to just remind all of us that we can only get the data if we manage to keep these babies alive. If these babies 500 grams don't live, we'll never have the data and we'll never know what happens to them. So it's very important to know that. Any other comments from the panelists? I think there are some questions that we asked. I think Dr. Swan asked the question. I think it was directed to our neonatal colleagues in terms of what do you use to resuscitate? Is it the weight or the age of the baby, the gestational age? What is your cutoff at the moment, your current practice?
Sorry, Dr. Verenga, please come again. You said, is it the age or the gestational weight or the gestational age that we use to resuscitate? I think it's both. It's not hard and cut in stone, but generally at a gestational age, I think we said below 24 weeks in this country is futile. Gestational age above 25 weeks, if the mom is well prepared and the parents are cancelled, well prepared as in she's received antenatal steroids, magnesium sulfate, she's in a good institution, and the parents, we've discussed with them, they are willing to try resuscitate, we can try. But at 26 weeks, we should be resuscitating all the babies.
What about the weight? What weight would you say no?
I think less than 500 grams.
Less than 600.
Incredibly low, but yes.
Another question, is it safe to say that the 26-week threshold proposed by NEOZIM coincides with the 700-gram threshold where there was no survival? How does it superimpose Dr. Venga's data on survival? I think this is your question again. It's not our question for us.
Is it safe to say the 26 weeks?
Threshold proposed by NEOZIM coincides with the threshold where there was no survival. In the data you showed, there was no survival. I know your numbers were small, very small.
Our numbers were small, and that was for 1 year. That was for 1 year, 2022. But as you can see, this one that Dr. Mazuzu just highlighted there was actually 680 grams and survived. So I mean, so it doesn't mean that we're saying that all those less than 700 grams, and I'm sure even Prof. Mujuru might also tell you that, she's managed other babies less than 700 grams who've actually survived. So we're not, it's just that the data that we showed for the year 2022, there were no survivors, but we're not saying that there are no survivors under 700 grams.
Right. So, yeah, I think when I looked at the two data, I think they mirror each other very well, except that my colleagues, maybe their categories were broken down into 100 grams each. But when I looked at the survival before 800 grams, I think our percentage is the same. Even before 1,000, it's almost the same percentage. It's about what, 60%, right? Before 1,000. So it was the same.
Yes.
Is it? Yeah, it was the same when I looked at your data. Yeah. So any more questions you may have from the floor? I think there's another question. Okay, I think this has been answered. Dr. Emmanuel Sando asked this question. Alex, do you want to comment? I thought, are you able to comment now? Alex is having challenge with the device. But one of the reasons why we gathered here is to allow we have some data that is showing that there are possibilities at different gestational age, but the numbers have to be known roughly to say how best, how good are we. We know there's international data. National data tells you something, you very good things, but the local data has to guide you in terms of counseling. We know the data is not yet complete. It's not yet complete because it's for a short time. These babies still have to be followed up 2 years. We're kindergarten, as school-going children, until people are very clear to say what do you mean with 100 grams is a good baby. But this data should help us. And this data will be available again on the Fetal Foundation ZIM website for those who missed. If you want to just have a good look at the data, including the one presented by NEOZIM, we'll put it on the Fetal Foundation ZIM YouTube channel for people to reference, to look and say, this is the best we can do. I know some feel that we should take government data, but the reason why we didn't take government data, the confounders are too many. You ask a baby to be delivered within 24 hours, baby will be delivered 72 hours as an MSP because the theater will be full. So honestly, we can't make a guideline based on that kind of data, where you know that if you say deliver the baby who is very sick, it cannot come out because the theater list is just too full. It will only come out a day later, 3 days later. So these are some of the challenges we have. So we think private sector data can help us, can help give the campus to how we ought to improve things in the public sector, to say if we work harder, the way people are working hard in the private sector, we can improve our outcomes by this much. This is my feeling. Of course, people are allowed to air their view, but I feel that the private sector data should help us have a canvas of where we should be going in terms of improving the public sector issues we know we have.
Can I make a last comment 1 minute before we end?
Yes, please, Prof. Go ahead.
I see that the private hospitals don't employ kangaroo mother care. Can I just find out what are the results of kangaroo mother care at Harare Hospital, and if there are any studies between normal care and kangaroo mother care in public hospitals, and why do the private hospitals not encourage and promote kangaroo mother care?
We do encourage kangaroo mother care both in private and in public. In private, in most institutions, we're doing the intermittent kangaroo mother care, where it's not the continuous, where mother doesn't lie down with her baby like at Harare Hospital, and baby gets continuous kangaroo mother care. So at most private institutions, we're doing intermittent. That means that mother comes in, she spends 2 or 3 hours with her baby on kangaroo mother care, and it's actually been shown to be beneficial and to have good outcomes, even with intermittent kangaroo mother care, as opposed to continuous. I think we're not getting the continuous in most private institutions because there are actually no beds in the facilities. But we as the neonatologists have a small neonatal unit. In our small neonatal unit at St. Anne's, we actually can do continuous kangaroo mother care, but we haven't had much uptake of mothers being willing to stay in the unit to do kangaroo mother care on their babies. I think the private mothers are used to going home and coming in, but we hope that with time, we'll have more mothers uptaking continuous kangaroo mother care, because the more you do kangaroo mother care, the better the outcomes. And then in terms of studies, unfortunately, Dr. Stevenson is not here, but I know that Dr. Stevenson and Dr. Max are going to be involved in a study in the public sector at Perinatal on immediate kangaroo mother care of babies. So studies are underway. I hope that answers your questions, Prof.
Yes, thank you very much.
Thank you, Prof.
Thank you, Dr. Mangiza. If I can say something, just in addition to what Dr. Mangiza said, I think the other barrier to continuous mother care, especially in our small unit, is the medical aid will not cover the mother's stay in the unit. So most mothers would prefer to go home. Once their 3 days are done, they prefer to go home and come back because the medical aid will not cover their stay. And as Dr. Mangiza said, yes, there's it's in the pipeline. We are planning on starting immediate kangaroo mother care at Perinatal. Still in the early stages, but it's coming, and hopefully that may actually show that the outcome of these babies actually improves.
Yeah,
Thank you.
If I can just add, sorry, my hand was up. I just wanted to say exactly what was said by Dr. Mazuzo, that the problem, there are some hospitals which were ready to start kangaroo mother care in the private sector, but the problem has been medical aid. We have, with medical aids, you have to fight for these kids. We fought for surfactant. Initially, when surfactant came, they didn't pay for surfactant. Even the medical aids which had the money did not agree to pay for it. We had to have a meeting and go there and tell them that they have to pay for surfactant. And the same must happen for kangaroo mother care. I must say that I have talked about it in some medical aid places where I sit, and they like, yeah, okay, we'll look at it. But we have to fight for it, because I don't see why there's enough evidence that kangaroo mother care definitely changes outcome, even for sick babies. Places put babies on a ventilator on kangaroo mother care, and they've got better outcomes. So it is us who have to fight for this, for these children, for medical aids to pay for it. I just needed to say, sorry, I then became a bit emotional because I really think we have to fight for our children. But my other last comment to the NeoZim team is that I have also noted that you need to look at mortality post-discharge, not just neurodevelopmental. I've lost quite a number of babies. They look well, you send them home, you think all is good, and then they don't pitch up. You call, you hear that, oh, sorry, we lost the baby, or they come because now they need to report. They don't want to get a postmortem, so you have to write a report, and you realize that the baby then died at home within a short time of discharge. So if you can make that one of the variables that you look at, because you really need to, we are losing some babies post-discharge. Thank you.
Thank you so much, Prof. Thank you, the two profs who commented, Dr. Madzizo, Dr. Mangiza. Our time is up. Yeah, our time is up. I think probably, let's say the discussion has been kindled, and the guideline which the NeoZim is proposing has been shared. The guideline is never a fixed document. It's always a living document. It can always be looked at as more and more information is available. I think the most important thing is that we need to gather the data so that we have more local data, more local outcomes, both short, medium, and long-term outcomes, so that that's the basis of how we counsel patients. Because we cannot continue to use RCOG, ACOG, and other guidelines when we are practitioners ourselves who are seeing patients every day. So yeah, so I think that's the challenge I want to give us. Is Dr. Stevenson in the meeting or no? So that he can comment again, you can give him time to comment. If not, I think we need to respect the time and end the meeting.
I think it's still not in the meeting, Dr. Renga. Yeah, he's still not in the meeting. He hasn't joined us yet. Yeah.
If he's not in the meeting, I think it's our time is up. Many issues to discuss, but we can always create other forums where we keep on discussing these issues, and we keep on working or improving the guidelines that we have before us. So thank you so much, everyone, for attending, and we are really sorry for taking your Friday away from you. We will continue to work together in a perinatal platform with the neonatologists, pediatricians, and obstetricians. We think these platforms are important because we are all caring after the same patient at the end of the day. Otherwise, enjoy your weekend, and